So I will be dividing this over two parts. First part, we will be doing the conventional imaging, like the non-contrast X-rays types. Okay, so first we'll do that. In the second part, we will do barium images, urinary images, IVP and all those, right? So we'll do it in two parts, covering all the important images that can be asked to you in your exam, right? So let's get started. Side by side, we'll also do some relevant theory associated with them. So when you are asked, commonly you will be given an X-ray. Rarely you will be given something fancy, like if you're doing very well, they will give you a CT image. But most of the times, X-rays, what they will ask you, it will be either a plain X-ray or a contrast X-ray. Now, how should a student describe an X-ray? Very important. The first thing you should see in an X-ray is which body parts X-ray it is. For example, is it an X-ray of the chest or an X-ray of the abdomen? Or sometimes they give you an X-ray lower down in the abdomen, which is called KUB, kidney, ureter, bladder, urological X-ray, very important. So first you tell which body part has been viewed. Second, you need to know, is it a plain X-ray or a contrast X-ray? Normally, a contrast X-ray would be something like a barium. So if you have an X-ray photo where everything looks very white, like the stomach is looking very white, it is a barium or an esophagus, right? So that will be a barium swallow or barium meal. We will discuss them in the second part. Or it could be an intravenous urogram, which is used for urinary tract evaluation. So these are the common contrast images. Third, you need to see are the positive findings. Is it a normal image? Or is it an image where there is something abnormal? 99% they will give an abnormal image, right? Obviously, why should they give you a normal X-ray unless they want to trouble you? So you have to tell the positive findings. And finally, based on these findings, you have to tell the diagnosis. So whenever you are going to describe any X-ray or any image, it should be, this is an X-ray chest, plain or contrast. It is in, if you know the view, so wherever applicable, you should tell the view. Where applicable, is it a AP view or a PA view or a lateral view? And then you tell the positive findings. This X-ray is showing this or that, and then give your diagnosis. Now I'll tell you what students often do in the exam, just to buy a little time. They say, okay sir, it's a chest X-ray. I can see two lung fields, I can see ribs, I can see sternum, it is well exposed, poorly exposed, all that thing. Cardiophrenic angle, costophrenic angle, cardiothoracic ratio. Examiner is not interested. Okay, if you are going to say all those things, rest assured the examiner is switching off. He's like, okay, you're just doing time pass, and he will tell you, doctor, tell the diagnosis. So if you know the diagnosis, please don't beat around the bush. Surgeons don't have the patience. They want to want you to come to the bottom of the situation. So please come to the key, right? So tell the positive findings unless you are buying yourself time. Examiner will catch it. Okay, so which is why it's better to go prepared. There are some standard X-rays which I'm going to discuss with you. You should be able to identify them comfortably, right? So let's get started. Let's show you how these X-rays are and what you are supposed to look for. This X-ray, 50% students get. 50%. It is that important. So how will I describe it? I will say this is a plain X-ray of chest. It is a plain X-ray of chest. You know why it is plain. There is no contrast given. But it's not only chest. I can also see upper abdomen. Right. It's a plain X-ray of chest with upper abdomen. Normally, X-ray chest is going to be PA view. Normally. Now, if you can't make out whether it is PA view or AP view, I'll give you a simple trick. When we do a PA view, person is standing and he holds the plate like this so that the scapulas go apart. If the scapular border is not coming in the field, if you don't see the scapular border, it's not coming in the field, it's a PA view. Because when he does this, the scapula gets abducted and you get a good view of the chest fields. Ideally, chest X-ray should be PA view. So if the scapula is not coming in the way, the clavicle is more horizontal, because when you do this, your clavicle becomes straight. Like this, if you are taking a AP view, the clavicle may be a little slanting. So if the clavicle becomes straight, the scapular borders don't come, it will be a PA view. Otherwise, it's an AP view. If you feel the diagnosis is very grave, patient is very serious, he wouldn't have done the X-ray in standing position, you say APView, like an ICU patient. If you see a lot of ECG leads or neckline, endotracheal intubation tube, if you see those things in the X-ray, don't call it PAView, that patient will not stand. Most of the time, surgeons don't care. Okay, they want to know the key part. So you will say, it's a plain X-ray of chest with upper abdomen. Tell the positive finding. Now, what do you see in this X-ray? What is the positive finding? Very important. You should be able to see this from a mile. Okay, you should be able to see this from a mile. What you are seeing here, this is the right dome of the diaphragm. This is the left dome of the diaphragm. There is a black area underneath. That black area underneath is nothing but a free air under diaphragm. So normally the area under the diaphragm should be white because there is liver on the right side. So it should look white or radio-opaque. This is a radiolucency. Basically that radiolucency is nothing but a free air. And this free air should be under, better to see it in both domes, but at least under the right dome. Because normally on the left side, you may see fundic bubble, but that's not free air, right? That is air in the stomach. Like you can see over here, there is a fundic bubble. Now you can't say for sure that is fundic or that is free air, which is why on the right, if you see anything, it is very important. So there should be free air under both domes of diaphragm. If you see free air under both domes of the diaphragm, you will tell the diagnosis. The diagnosis is going to be intestinal or hollow visceral or a GI perforation. It's a hollow visceral perforation, specifically of a GI organ. Like a duodenal perforation is a common cause, but it's not necessarily duodenal, it can be other causes. The moment you say this, basically this is just a starting point to take your viva somewhere. So then the examiner will ask you about duodenal perforation and so on and so forth. So it's these table viva topics are just to test your theory and practical knowledge about that concept or about that disease, not just to pick up the diagnosis alone. So you may very well, someone must have told you, oh, there is an X-ray like this, and there is some name written over there, maybe name of the patient is written over there, and that X-ray is free under diaphragm. So don't go by that. Examiner may know you knew the diagnosis before, so he will take the viva on that topic. So what expected questions do you get on this? Is free air always due to hollow visceral perforation? Answer is no. One is it can be because of hollow visceral perforation, most commonly duodenal ulcer, ileal perforation, but it can be for other reasons. Like it can be because of post-operative patients, post-laparotomy. Because when you do laparotomy or laparoscopy, for some days some air from the environment will remain. Post-laparotomy, post-laparoscopy, post-ascitic tap sometimes. There can be free air which has entered the abdomen, or rarely, even rarely, it can be because of abscesses in the abdomen, like a liver abscess, because of gas forming organisms. So a gas forming organism, emphysematous liver abscesses, emphysematous renal abscesses can give you some free air. This is the very basic they want to know. Further, if you can answer here, they will ask you how much air should be there to be seen on an X-ray. It should be more than 20 to 30 mm. Okay, on an X-ray. CT scan will pick up even 1 or 2 mm of free air, plain CT. But X-ray, especially in an erect position, you need at least 20-30 cc of air. If it is less, it may be missed on an X-ray, it won't be picked up. Then they will ask you about management of peptic ulcer perforation. So you should know, you will admit the patient, you will stabilize, give him IV fluids. And obviously the treatment is going to be surgery laparotomy, where you will do a Graham's omental patch closure. Okay, you will do a Graham's omental patch closure. And if you can reach till there, maybe they will ask you, tell perforations where free air is not seen. Okay, so one is the obvious answer. If it's a perforation of a non-GI organ, like a gallbladder perforation, you won't see free air, obviously. Or a urinary bladder perforation, obviously. But then they will be like, okay, the student is very smart. Let us give him another googly. Any perforation of the GIT where you may not see free air, even on a CT. Answer is appendicular perforation. Remember, appendicitis occurs because of